Good afternoon, colleagues and friends. My name is Heng. I'm a radiologist from Tock Hospital and a lead for an MOH project on acuity, the appropriate criteria for use of imaging technology. Today's webinar has been designed to educate and discuss with our participants the MRI for low back pain, appropriate care guidelines, or ACG for short. In the next 1.5 hours, you should be hearing from our multidisciplinary expert panel the clinical considerations behind the guideline recommendations and its practicality of use, ending off with a Q&A session. Before I continue, 2 housekeeping matters to note. Your mic, video, and chat functions have been disabled, but you can send your questions through the Zoom Q&A function at any time during the webinar, and our expert panel will do their best to answer them during the Q&A session. So next slide, please. So our 3 speakers for today are Prof. Gameliel, who is the Director of Spine Services, Orthopaedic Surgery at Fong General Hospital and Chair of the MRI for Low Back Pain ACG Formulation Work Group. Dr. Tsou is a musculoskeletal radiologist in private practice and the immediate past president of the College of Radiologists. Dr. Kamal Verma is a neurologist at NNI with subspecialty expertise in entrapment neuropathies as one of his clinical interests. So before we begin the session proper, go back to the next the slide before this. I would like to conduct a quick poll of 2 questions to get a better sense of our attendee profile. We will take a minute each for each question to be answered. So the first question is, what is your clinical background? And we have listed a few options: primary care, specialist care, allied health, and others. And for the second question, how many years have you been practicing? 1 to 5 years, 6 to 10 years, 11 to 15 years, or more than 15 years? We'll give a minute for the participants to fill up the polling. Thank you. Okay, and it's good for us to know the profile of our attendees. Slightly more than half are from primary care, about a third from specialist care, and a small proportion from our allied health group as well as others. And in terms of the duration of practice, the majority actually, 60% have been practicing for more than 15 years, and a roughly equal distribution among the rest for 1 to 5 years, 6 to 10, as well as 11 to 15. So thank you very much for completing the poll and giving us a sense of the audience attendees today. Right, let me move on now to the session proper. And before I invite the speakers, next slide. Yeah, next slide. I'd like to talk about the motivations behind this ACG. For those who have not seen the document, you can download the ACG from the official site via the QR code that is shown on this slide. We all know that low back pain is a common occurrence, and in fact, it leads to more years lived with disability than any other condition. Evidence on clinical utility of MRI and imaging in general for low back pain is well established, but sometimes deciding who should receive MRI of the lumbar spine can be challenging without guidance. So the ACG is meant to be an evidence-based clinical guidelines with inputs from relevant experts from the various colleges under AMS, for which we systematically sort through a formulation work group. And even though it's not explicitly stated in the document, the work group was sensitive to concerns such as patient preferences and medical legal implications that exist in practice. So without further ado, I would now like to invite Dr. Verma from NNI to discuss his clinical approach to a patient with low back pain. Dr. Verma, please.
This is an important topic that we all have to consider, as just by the sheer number of patients who come to the neurology clinics, or for that matter, other orthopedic clinics as well. I think in a study in US, low backache accounted for the third of visits to the clinics. So it becomes an important topics to discuss what are the possible neurological aspects we should consider. And can I have the next slide, please? So as the patient would come to our clinic, so the assessment remains primarily clinical. And this is done to determine what is the likelihood and what is the type of the underlying spinal pathology. It is important that we try to find out whether the pain which patient is experiencing, is it coming from the spine or is it some non-spinal pathology such as osteoarthritis of the hip or sacroiliitis. Another important consideration when patient comes to the clinic is whether the pain is acute or chronic, and then whether there are other clinical features that require further investigations or a particular management approach, because this would in the end determine how we approach this patient for the investigations. Always remember, the decision regarding the spine imaging then depends basically on the patient's clinical presentation. Can I have the next slide, please? So how do we differentiate a non-specific low back pain and a specific spinal pathology? When it comes to the neurologist, I think history becomes the most important. So when the patient comes to our clinic, essentially we have to look at the description of the pain coming from the patient in his own words, but of course with all the necessary pointers that we look at. So what is the pain description? Is it, as we spoke about, is it acute, which is typically considered between 2 to 4 weeks? Or is it subacute, up to 8 weeks or so? Or is it more chronic, which is 8 weeks or up to 12 weeks or even more longer? The pain itself, the description of the pain, where does it really localize? Does it actually, is a musculoskeletal type, which is in the low backache? Sometimes the patients will just put it like a pointer towards in the center of their low back, associated with some paraspinal tenderness or spasms. Or is it a more neurological in nature, that is, patient is complaining of shooting, lancinating, or even burning pain going down to either of the extremities? Severity is important, but we have to take in account that it is variable depending upon the psychosocial factors, sometimes the cultural factors, and other things, including sometimes things like workman compensation. Triggers are important to identify, so as well as the relieving factors. So the patients with the MSK type pains, which is osteoarthritis or sacroiliitis, as well as the neurological, like a radiculopathy pain, patients will feel generally better when they stand up. They feel much worse when they are sitting, or even they feel better when they are lying down. Compared to that, some of the specific osteoarthritis pain is actually worse when the patients are standing and walking, and they feel better when they are sitting and lying down. So does also happens in conditions like spinal stenosis. Sacroiliitis, another common condition from the musculoskeletal point of view. Generally, patients feel much worse when they are transitioning from standing or sitting, or even when they are lying down, they don't feel so good. So some of these things will help us to see what is really happening in terms of this pain. And then it comes the physical examination, where you do look for things like whether the patient has any focal wasting or any neurocutaneous stigmata. And the specific test for the radicals is conducted. SLR remains our standard test, which is a straight leg raising test. The test is typically considered positive when the passive raising of leg results in a pain between the 30 to 70 degrees of the stretch. If it is beyond 70 degrees, then this is physiological. If it is below 30 degrees, then sometimes it's non-organic. The test can be further augmented if, by just dorsiflexing the foot as the stretch goes on, or sometimes just letting the other leg being stretched passively up to elicit the pain on the affected side. This test is essentially done for the lower roots, which is our L5S1 roots, which is the most common presentation, as accounts for the 95% of the lumbosacral radiculopathies. Femoral stretch test, which is done for the upper radicals, which is your L2 to L4, is essentially done with the patients lying in a prone position, and the leg is then raised passively and flexed at the knee. A pain at the anterior aspect of the thigh, which is shooting in nature, is then considered as positive. Patrick test, which is essentially another name for the Faber test, is a flexion, abduction, external rotation, which brings the ankle of the affected side on towards the contralateral knee. And when you push down and the patient feels the pain, that's typically more on MSK nature. So after doing this physical examination, then you go more specific neurological examination. And keeping in mind that this neurological examination may give you some findings, but that doesn't necessarily mean that we need to straight away send the patient for further investigation. So can I have the next slide, please? So if we see this particular page, it's a little busy slide, but it tells us about all the necessary roots and segments which are affected in a low backache. It tells you about the pain distribution, the weakness patterns, reflex abnormality, and the sensory symptoms or distribution of the findings. Important thing is to remember is that weakness, which is a hard sign along with the reflex abnormality, takes the precedence. Sensory examination, unless it's quite conforming to the different roots or different radicals, it can sometimes be rather non-specific. And the examination can be further augmented. And so besides doing the specific examination, I place a lot of importance to the gait and some of the augmented gait stress testing, which is essentially asking the patient to walk on his toes and heels, helps you to look further whether the patient could be having a subtle weakness. So all in all, if this examination is carried out, we can have a good mix of findings, which will tell us whether the patient is having significant deficits coming from his complaints. So can we have a next slide, please? So what do we do after all the neurological examination we have done? Of course, one thing is that to remember that despite having the findings which we had seen earlier, if these findings are subtle and mild, they are self-limiting. And most of the time, patients would feel better in 1 to 2 weeks, and we do not necessarily have to intervene early on. However, we always have to look for the red flags. Red flags become important because that will urge us to intervene early, whether it is in terms of the investigations or referring the patient to a specialist. When it comes to the neurologic red flags, it is essentially we are talking about the red flags in the chora equina region, which is all these lumbosacral roots as they come down. So the symptoms such as bilateral signs of weakness as well as numbness, early bladder or bowel dysfunction, which is coming up along with these bilateral signs, or subtle anesthesia, or altogether just the rapid progression of any of these neurological deficits should be considered as a neurologic red flag, and patients should be referred early and maybe even require early scanning. The non-neurologic red flags, I would probably let Dr. Gameliel speak later, but essentially you are looking for whether this back pain could be related to a cancer. And the most important thing typically is a prior history of cancer, unexplained weight loss along with it, or the red flags for the spinal fracture, which could which could come out because of a trauma, or if the patients are frail, older, or just younger patients who are on the chronic steroids. And then infection, if the patients are complaining of fever, or there was a recent infection or hospitalization, or there's a history of IV drug use. So all these things will become a red flag for a possible spinal infection in a patient who's complaining of fever, who's complaining of a backache. So these red flags should always be kept in mind, and then we should formulate our plan as to what investigations and intervention should be done. So I think this is probably my last slide. Could we move forward?
Thank you, Kamal, for highlighting the important clinical considerations in dealing with patients presenting with low back pain. A gentle note to everyone that you can send your questions through the Zoom Q&A function anytime, and we will try to have them answered in the latter part of this webinar. Next up, I would like to invite Prof. Gameliel Tan to share his perspective on managing patients with low back pain. Over to you, Gameliel.
Thank you, Heng. Hi, I'm Dr. Gameliel Tan. I'm a surgeon, spine surgeon in Fong Hospital. Can we go to the next slide, please? So some of the features that would require a surgical consult, that's cases of, what are the cases that you would refer to a spine surgeon for consultation are basically two things. Spine surgeons are really looking for neurological deficit due to cord compression at either the T11 or T12 L1 region or nerve root compression. So this will be manifested by severe and persistent neurogenic or radicular pain. All right. The other thing is, of course, severe and debilitating mechanical back pain that would either indicate fracture or something that destabilizes the back and that would require surgical intervention. So these are the two main things that we are looking for, either neurological deficits or pain or mechanical back pain. Other things that Kamal also mentioned would be red flags. Things like cauda equina compression or spinal cord compression as manifested by either the history or the physical examination of a weakness or lax anal tone. And then other constitutional symptoms like fever, loss of weight, night sweats, or pain at night. These are other red flags that we also need to look out for in our practice and that would require a surgical consult. Next one. Okay, so while this seminar is based on the MRI, we're talking about the MRI for the lower back pain, it doesn't mean that we don't do basic X-rays for patients with low back pain. So the X-ray is important because it still allows us to see the alignment of the lumbar spine, both in the AP and the lateral view, and you can see whether there's any loss of lordosis, which can occur in acute lower back pain, or whether there's any spondylolisthesis, meaning, let's say, a slip of 4/5 or 5/1. It also allows us to look for any deformity. Most commonly we see is scoliosis, either in the pediatric or in the degenerative elderly population. In the case of trauma, if the patient had a fall, you also can look for fractures. Easy screening X-ray can let us know whether it's a compression fracture or otherwise a more severe fracture. And it also allows us to look for lytic lesions, for example, pedicle destruction in the case of metastatic or primary spine tumors. If the patient has any constitutional symptoms, we can look for infection by the loss of the psoas shadows with their fever or night sweats. Of course, the most common thing is degenerative changes in our aging population, right? So a lot of patients that we see have loss of disc height or osteophytes that are seen on the plain X-rays, and just showing this to the patient, it allows them to understand why they're having localized back pain. The X-rays, if it's well taken, it will also include the sacroiliac joints, and you can see whether there's any sacroiliitis. Of course, the choice of imaging depends on the type of suspected spinal pathology, but X-rays do have an important role for the initial assessment of low back pain before we proceed to more advanced imaging. Next slide. Okay, I have a polling question here. The question is, what proportion of patients referred to the specialist outpatient clinic ends up with surgery? So the choices are more than 15%, 11 to 15, 6 to 10, 1 to 5, and less than 1. Okay, I think most of you have answered with 185 responses, 186. Well, the answer is less than 1% actually require surgery when they're referred to the spine surgery outpatient, specialist outpatient clinic. Most of them have actually do well with non-surgical management. Okay, so that's the answer. About 20% end up with MRI, and 1% or less than 1% require surgical intervention. Okay, can we move to the next slide? Okay, so most patients with low back pain do not require MRI. And what I mean by that is they don't require, most of them don't need an MRI because they don't have neurological or radicular symptoms. They're coming in just for acute back pain or neck pain. We usually just send them for physiotherapy. Okay, so the decision for advanced imaging It really depends on the history and the physical examination. And also sometimes it depends on the patient's presentation and their preference also. All right, so less than 20% end up with MRI and less than 1% end up with surgery. Next slide. So 99% of the patients, actually conservative management is the mainstay for patients with low back pain, as most of them are musculoskeletal in origin. And including even if you have a slip disc or spinal stenosis in a degenerative condition, most of them, actually don't need surgery. Most patients with a slip disc or spinal stenosis, if it's not debilitating and they're still able to do activities of daily living, they actually do well with first-line treatment. So initially, when they're in acute pain, let's say they have acute slip disc or acute exacerbation of spinal stenosis, we just advise them just to take some painkillers and then to rest for a day or two. Then once their pain is better, right, they can move on to structured exercises like physiotherapy when they're able to move a bit better. Sometimes some patients also like to go for massage, manual therapy. It helps them to loosen up the tightened muscles. So once the muscles are looser, they can actually do range of motion and mobility exercises that allows them to be more flexible. All right, and we also do in the initial phase, if their pain score is 4 or 5 or 6, which is moderate to severe, we do prescribe them some non-steroidals and muscle relaxants, and we can titrate it according to the level of pain. We also give them gabapentin or pregabalin, Lyrica, if there's radicular pain. Opioids, sometimes we do give tramadol, but that's actually the maximum that we give. We don't go into anything more powerful than that in the outpatient clinic. So a combination of pharmacological, manual therapy, physiotherapy, and most of them, actually 99% actually do quite well with these modalities. I think, okay. Okay, that will be my last slide.
Yeah, thank you, Gameliel, for your insights. Now, to make the session more informative, Dr. Verma has kindly prepared 3 case studies to illustrate the appropriate use criteria for MRI of low back pain. Over to you, Kamal.
Thank you. I think the case scenarios which I have kept are more simple, straightforward, and probably I would say more based for the primary care. But can I have the first of the 3? Next slide, please. So this is a polling question, and I think I'm assuming that you have read the guidelines which have been formulated by ACE before you decide how do you answer this question. So a 50-year-old male reports acute low backache or low back pain after a new exercise regime. He stops exercising and has rested for a week. He's currently still taking Panadol as a PRN. He comes to you still being symptomatic and he's worried. A neurological examination is normal, but he's requesting an MRI. Would you order an MRI of the lumbar spine for this patient? Your answers could be yes, there is likely a specific spinal pathology. No, it's non-specific. And maybe looking at the patient's overall condition. So we will take about some period. And as I can see, the buildup is that this does follow our guideline number 1, which is for a non-specific MSK pain, it is usually self-limiting, and it's not necessary that we should order any scanning or any imaging early in this phase, and patients should be ideally symptomatically treated, but always should be kept on a follow-up for any possible red flags. So we can end the poll here, and I think, yes, this does follow our guidelines that we would not like to do an MRI in such a patient. Okay, let's do the next question. A 61-year-old man with type 2 diabetes has had low back pain for several years, or several months, sorry. The pain is aching and cramping, occasionally radiating down to either legs. He needs to sit and rest after walking to a nearby grocery store, and he feels better when bending forward over the grocery cart. Neurological examination shows reduced ankle jerks, however, otherwise is unremarkable. So would you order an MRI of lumbar spine in such a patient? Yes, because there is a specific pathology. No, it's likely non-specific localization, or maybe. So answer to this question is that we probably are talking about a patient who has a spinal stenosis. This is a typical picture of what we call neurogenic claudication. And sometimes this also depends on the patient's functional status, whether these patients are still actively working in the community or they are essentially leading more sedentary life. In such situations, actually, answers could be any of the three, including maybe, because if you can see his examination is very minimally positive in the sense the reflexes being down could also be because of his diabetes mellitus and not necessarily indicates that he has a very narrowed L5S1 area of the spinal canal. But saying that if it's significant for him to give him debilitating pain or affecting the quality of life, it can be done. But I would probably go in such a patient, I would give him some time, do some physiotherapy and see how this patient does over a period of time. And then I will take a decision based on the quality of life. So my answer would be, for myself, would be maybe at this stage, depending on the patient. But yes, there is no definite answer that we should not do it in such a scenario. So this would be one of those questions. Okay, can be the third question now? Next slide, please. A 46-year-old woman working at home for the past 6 months, juggling household chores, has acute low back pain. Is greater when she is sitting in a home office. She has a sour feeling along the lateral calf area at times. It is relieved if she moves out of her chair and moves around for some time. Examination shows tight paraspinal muscles, positive SLR at 50, and a normal neurological examination. So would you order an MRI in this specific patient? Yes. If this is a specific pathology, no, it is non-specific and maybe. So if we look at this patient, this patient who has been sitting for the past 6 months, very sedentary life, poor posture, but does have some flavor as if possibly the L5 radical is affected in this patient. But otherwise, the examination is rather normal. So based on the ACE guidelines, actually, even though the patient has radiculopathy, which is an early radiculopathy, we may not have to order an MRI early on, as this may be self-limiting. Such a patient, if she's given an adequate posture-related exercises, avoid the deconditioning which is coming in from sitting for long hours, actually it may just self-remit, and we do not have to pursue it further. It is well known that patients who go for early MRIs for such low level or low grade of symptoms, and it have also been found that at times they have gone for early surgery in certain settings. And they found actually a very nice study that the quality of life after a surgery in such patient was much worse than the patients who did not undergo any of these things and they just had the conservative measures. So based on our guidelines, which is the ACE guidelines number 2, I think this is, my own answer would be that no, we would not like to do an MRI at this point. Although this is a specific spinal pathology, early radiculopathy, which is mild, maybe self-remitting, and we may not have to, right away do an MRI because that may just increase anxiety in the patient. So I hope these 3 questions do answer some of these more vague, scenarios, which actually are the more common in our clinical practice rather than the most, devastating or catastrophic things which happen in the cord equina, which are anyway picked up in the emergency rooms. So I think with these 3 questions, I would probably end my question and answer session here. Thank you very much. Can go ahead.
Thank you, Kamal. Yeah, thank you, Kamal, for your interesting case discussion and the audience for your active participation. To translate the ACG into practice, we have been working with the Seng Health as well as the Fong General Hospital EMR teams to hardwire the ACG into their radiology order forms. Prof. Gameliel, who also champions the IT rollout as a CMIO in Fong General Hospital, is also here to share what it looks like for the clinicians in his hospital. Gameliel, please.
Thanks, Jane. So we have already implemented the guidelines into our electronic health records. Next slide, please. It has actually been done in the Seng Health system, and we just recently rolled it out to our Epic system in Jurong Health in Fong Hospital, and eventually it'll be rolled out to the entire NUHS and National Healthcare Group also. So within the Epic systems for these two clusters, once it's live, when they get it, you can see that the first box on the left-hand panel shows MOH appropriate care guidelines, ACG indication. And you can see a red exclamation mark, meaning it is in a hard stop, meaning that users will have to populate this field before they can sign and accept the order for the MRI. And once the user goes to this box, you can see a drop-down list on the right-hand side. And within the drop-down list, the user can select several indications for the MRI of the lumbar spine. They are suspected cauda equina syndrome, suspected or known cancer or infection, progressive neurological symptoms or signs, new or progressive pain, post-invasive spine surgery, pain more than 4 to 6 weeks post-conservative treatment. Then further down the list, you can see that there are some with asterisks. These are non-specific pain less than 4 to 6 weeks, patient requests, and others. Should a user choose one of these with an asterisk, they'll be prompted to put in a free text and to specify why would they be ordering an MRI. Okay, so these are the ones that may not be appropriate. It doesn't mean that we are stopping them from ordering the MRI, but we do collect the information from all these reports later on for further analysis. Okay, so the guidelines are guidelines. They are not meant to stop the ordering physician, but they are more to prompt them to think, why am I ordering an MRI lumbar spine? Is it appropriate or inappropriate based on the guidelines? But if it's inappropriate, you still can go ahead and order it. And then at the last bottom part, there's in our hospital, we have an intranet reference link for the guidelines of when to order a scan for low back pain. Next slide.
Yeah. Thank you, Gameliel, for sharing your Fong General Hospital experience. I would like to now invite our third speaker this afternoon, Dr. Tsou, to share the radiologist's perspective on this ACG. Ian, please.
Thank you, Cher, and I'm glad to be part of this working group. So I'm going to show images of MRI. We've talked about sort of like the front, how to approach the patient with back pain and all that. And I'm going to complete the whole story by showing what an MRI is, what images of, and some sample images of serious and non-serious conditions. Next slide, please. So most radiology departments in the hospital have some form of workflow for screening of imaging requests. As you can imagine, there's quite a number of imaging requests, and especially for advanced imaging modalities or interventional procedures where the resources are not necessarily easily available, we have to do some form of triage. Next. So screening of these request forms so that it's a form of triage so that urgent cases can be prioritized, and of course the scan given to the patient who needs it more urgently. Also, the second role of the radiologist in screening the forms is to select the most appropriate imaging method or modality that will answer the clinical question or situation, because a lot of times there's a choice between different types of imaging modalities, X-rays, ultrasound, CT scan, and MRI, or even which body part is to be scanned. So the radiologist role in this case is actually to give advice and guidance onto what is the best method to answer the clinical situation. Next, please. This is what an MRI scan looks like. Okay, so my radiographer is actually positioning the patient who's lying on the MRI couch. And this is just before the patient goes into the center of the bore or the tunnel of the MRI. You can see that the patient has headphones on, which actually provides some music, and it also allows us, the radiology staff, to give instructions to the patient. So before getting an MRI, one of the things that we do when the patient comes to our department is that, first of all, they need to be screened for any contraindications. And especially for MRI, because there are quite a number of safety issues related to magnetic devices or implants that might be in the patient. So we go through the whole procedure of the MRI, what the patient is to be expected. And for MRI of the lumbar spine, they're placed in a supine position, their hips are flexed a little bit, and they're made comfortable. The reason for this is that they need to spend maybe about 20 to 30 minutes in that position with as little or no movement as possible, because any repeated movement will actually cause the images to be blurry and may not be optimal for diagnosis. Okay. Our staff will actually also coach the patient through each sequence of the MRI. So we give them instructions, how long more to go, what to expect, so that the patient can actually tolerate and go through the procedure. Next slide, please. So this is an example of what a normal MRI of the spine looks like. This is the sagittal view. So it's as though we are looking at the patient from the side. And the three images, which are labeled T2, STIR, and T1, are actually the different image weighting that we apply to the MRI to allow us to see the different tissue characteristics. You can see the squarish vertebrae inside all of these, which are normal, and they're normal in height and alignment. And in between them are the lumbar intervertebral discs, which are the most common pathology that we see in degeneration of the spine. In this patient, you can note that all the discs are normal in height. They're equivalent to each other. The central area, which is whiter on the T2 and the STIR images, indicates that these discs are very well hydrated. So they have a gel-like nucleus with a lot of liquid content inside it. Surrounding each disc is a very black or dark rim, which is actually the annulus fibrosis, which actually serves to contain the gel-like material inside the disc. You can imagine the disc is, as one of those stress balls or squeeze balls. The center of it is gelatinous, and there's an outer rim that encases it. So again, same like a stress ball, when you put pressure on it, when we stand, when we walk and jump, our body weight is actually applied onto the disc. But they go back into their normal shape after the pressure is released. So in this patient, all the discs are normal without any posterior disc bulge or herniation, which is what we see in degenerative disease of the spine. Next slide, please. So we've talked about some what we call red flags or serious conditions, which actually do require MR imaging for complete evaluation of the patient's condition. And this is one example of that. Next. On the image on the left side, you can see a red circle, and you can see that the L4 vertebra is very abnormal compared to the level above and below that. First of all, it is lower in height, indicating that it's collapsed or partially fractured. And the signal or the color of it inside is gray, which means that it's replaced by material instead of the white, which is the normal fat inside the vertebral body. Next, please. The middle image shows that there is actually posterior retropulsion of the vertebral cortex. Because of the collapse of the vertebra, the marrow and the tissue actually has to go somewhere, and it actually goes backwards into the spinal canal, where there is compression on the spinal the chorda and the nerves at that point at that time. Next, please. On the last image on the left side, you can actually see that the yellow arrow shows the transverse or cross-sectional view. And this retropulsion of it has also caused a lot of compression and narrowing of the spinal canal at that level. Next, please. So this describes the appearance of this MRI study, where there's marrow replacement and collapse of the L4 vertebra. There's also retropulsion of the posterior cortex and compression of the spinal canal. And the clue in actually this patient's diagnosis, next, is actually this last area indicated by the green circle. So it's not just one vertebra that's involved, there are several other vertebrae involved as well. And the green circle highlights the abnormality in the S2 level. So this patient has metastatic disease, next please, from lung carcinoma. Next slide, please. So this is another example of a patient who has a serious condition which warrants MR imaging for evaluation. Next, please. So the blue arrows again show that there is actually abnormal signal within the marrow of the L1 and L2 vertebrae between the blue arrows. In this case, the abnormal tissue has also breached the anterior cortex of both vertebrae. Next, please. And as shown by the red circle, this tissue has actually spread out into the paravertebral areas. The middle image is actually what we call a T1 post-contrast image, where we give contrast medium to highlight any abnormal areas. And you can see that there's actually a irregular central darker cavity, and the rim of this cavity is actually enhancing with contrast. Next, please. So this patient has discitis, which is an infection of the intervertebral disc. It has also spread and caused erosion of both the L1 and L2 adjacent vertebrae. And this has also formed an abscess in the left paravertebral region. However, the story doesn't end there as well. Next, please. On the last image on the right side, which is a coronal image of the lumbar spine, the green arrows actually shows multiple pockets of fluid, which the upper one is less well defined and the lower one is quite well defined and oval in shape. This lies within the psoas muscle, and this infection has also gone on to cause psoas abscess formation. Next, please. In addition, there's also hydronephrosis seen in the kidney because the abscess has also encased the ureter as well. So the yellow arrow actually shows the hydronephrosis because of the ureteric obstruction. So this is an example of infection or discitis that does require MRI to evaluate fully the condition and the extent so that the appropriate treatment or surgery can be planned. Next, please. In another patient, this is a preoperative MRI scan done in June 2021, and the sagittal image on the left and the axial image in the center. The blue arrows actually show a small left paracentral disc bulge. So if, again, on the left side, if you compare to the intervertebral disc above and below the abnormal level, you can see that the disc is narrower in height, is darker, and actually protrudes or bulges backwards into the spinal canal. Next, please. So the patient had microdiscectomy done, but this patient was one of these very active person and believes in, achieving a target of 1,000 steps a day. Unfortunately, she didn't stop her exercise long enough after the surgery, and she continued with her exercises. Next, please. So 2 weeks after surgery, unfortunately, we had to scan her again. And these images, again, the sagittal image in the center and the axial image on the left side, next please, show that the yellow arrows show the area of the surgical defect where the surgeon actually went in through the lamina to remove the original part of the disc. Next please. But the red arrow actually shows a new area of disc protrusion or herniation, which actually is larger in size than the original disc bulge. So because after surgery, there's obviously still a point of weakness and a period of time we need to allow, scar tissue to form so that the area where the surgery was done is not so weak. Okay, so this patient unfortunately had to have a second surgery. So any recurrent pain after recent surgery and then with the appropriate indication and conditions would actually warrant a repeat MRI, irregardless of the duration of the time since the previous one. Next, please. So again, sorry, just to compare the before image in the center and the after image with the red arrow. Next, please. So the last set of images that I'm going to show is again in a patient who has significant conditions. This is quite an elderly patient who's 85 years old, and the working diagnosis was spinal canal stenosis. So again, I won't go through every single abnormality on this slide, partly because there's so many levels and so much abnormality, but just safe to say that there's a lot of disc degeneration, or the discs are flatter than the abnormal arrows. There's also spondylolisthesis of L4 and L5, where there's a shift in the position of the lumbar vertebrae, as well as facet joint hypertrophy and enlargement due to degeneration of the facet joints. Next slide, next click. The green arrows show actually, the green arrow in front actually shows the posterior disc bulge, while the green arrow at the back shows the facet joint hypertrophy. So you can see together these actually contribute to cause narrowing of the exit foramen as well as compression on the nerve root at that level. The opposite nerve root is, you can well see it on the left side, but the right L4 nerve root is squashed between these two structures. So this gives radiculopathy or sciatica. Next slide, please. So thank you very much. I mean, this was just to show some examples of conditions which represent red flags or serious conditions with which the MRI is useful in elucidating the patient's conditions and helping to decide management. Thank you.
Thanks, Ian, for illustrating the number of the ACG clinical scenarios with real-life MRI examples. We have now reached the final section of today's webinar. This is the Q&A session. And thank you very much to those of you who have already sent your questions in even before today's webinar. For the rest of you, please feel free to put in your queries through the Q&A function. We will continue and we will do our best to answer them in the time allocated. So perhaps let me just start off with the questions pertaining to the red flags. And here perhaps I could get Gameliel to answer. So I think there was a question posted on the type Q&A chat that there are also non-vertebrogenic causes of low back pain, such as leaking, AAA, aortic dissection, as well as pyelonephritis. And maybe for the benefit of those who can't be reading the answer directly, Gameliel, would you like to discuss a little bit about the use of MRI in patients with conditions that are outside of the lumbar spine, outside of the stated clinical scenarios? Thank you.
Yeah, thanks, Cheng. Yeah, this question was raised. I think there are non-spinal conditions that also can present with thoracic pain or lumbar pain. And I think the scenario given was, of course, aortic aneurysms, abdominal aortic aneurysms, pyelonephritis. And of course, we must be on the lookout for this, especially, of course, in the emergency department where if they present with acute pain and all with constitutional symptoms like fever and back pain or flank and for positive renal punch. And of course, all these are the other causes of pain that can be due to non-spine causes. And then we have to investigate those accordingly and exclude them, because these can be also life-threatening also. And of course, I think the same person, the same doctor has also mentioned that yes, should not be MRI be considered only in patients with pain not responding to specific non-interventional and it's severe pain and therefore being considered for surgery or local injection procedures. Yes, I think what we are trying to say here that MRI is an advanced imaging modality, right? I did speak earlier about the history and physical examination, same as Dr. Verma. And then also the plain X-ray that also can give more information. And then if needed, if there are radicular symptoms or there is chronic back pain that is more than 4 to 6 weeks, and then you're thinking about whether or not there's a nerve compression or whether there's a need for surgery, then the MRI is needed to confirm the diagnosis. What percentage of patients who receive an MRI spine end up with surgery? So just from the Fong, just from my own clinic, we see about 10,000 patients a year with the spine SOC. And as I mentioned before, 20% of them end up with an MRI. And then of those patients who received MRI, 4.7% end up with surgery, or about 1% of the total SOC patient, but about 4.7% of those who get the MRI. So again, most of the MRI that we do, let's say we do 100, only 4.7 actually require surgery. And again, doesn't mean it's inappropriate, because I also mentioned that a lot of times prolapse disc or spinal stenosis also get better with conservative treatment.
Thanks, Gameliel, for answering that. And there is an interesting question concerning patients with potentially caudal equina syndrome. And here I would like Kamal to answer. So the question was, for patients with urinary incontinence with back pain, no numbness or weakness, could it be caudal equina syndrome? And there was a similar question posed by one of our attendees today. Is there an easy way to differentiate bladder bowel dysfunction caused by spine pathology from other causes like BPH and female stress or urge incontinence? Kamal?
Yeah, so I think it's usually a constellation of signs and symptoms which helps us. I mean, so if we do have patients who have urinary incontinence, I think, is it associated with other features of caudal equina? So I think we need to look at the patient's perianal sensation, as well as the sphincter tone. That can go some way to look at these particular levels. But on the other hand, for the urge incontinence, which comes in the older women and all that, usually they are related to the increased intra-abdominal pressure. Saying that, sometimes if there are no accompanying signs, I think if you're finding your urinary incontinence, or is it overflow incontinence, is the first presentation, then you have to think of whether it's a conus lesion. So sometimes a spinal cord pathology or a conus lesion also may present the same way. So I think this requires a more thorough examination, and then we typically go through the whole process of whether a patient does have associated signs and symptoms of caudal equina or not. So I would say yes, most of the time we can, but definitely it's not that it could not be a mixed picture as well, depending on the age of the patient. So we have to be just keep in mind all the possibilities. Yeah.
Thank you, Kamal, for answering that. And we have an interesting series of questions related to the value of X-rays. And I think here I would like to invite Gameliel, as well as perhaps later Ian, to share their perspectives. So I think some of the questions that have come up pertain to the usefulness of spine X-rays from the orthopedic perspective. And perhaps we start off with Gameliel. Would you like to kind of discuss this in light of your current practice?
Yes, thanks, Shane. I think just we had already discussed the X-ray. There was a previous slide on that. But for orthopedic surgeons, even though we have an MRI, the X-ray do serve the purpose of a few things. One, we have to localize the level of the pathology. For example, if you're going for L4-5 discectomy, and we usually have to localize it. We have to localize it in the operating theater with a C-arm, with the image intensifier, and that's an X-ray. So we correlate it with the X-ray and done in the clinic versus those in the operating theater to make sure we're on the right level. And sometimes you have a sacralized disc or a sacralized level or a lumbarized level, then it makes counting levels even more difficult. And that's why the X-ray is needed, especially if you're doing thoracic 11 or mid-thoracic levels. That's where counting levels is very critical to make sure that you're operating the right level. It also gives us information on the sagittal balance. And if you know, NUH has the EOS machine, it gives you a total head-to-toe scan, and it gives you whether the patient is kyphotic, and it's important for deformity correction. So X-rays are still needed for these two things.
Thanks, Gameliel. And here I'd like to also pose a similar kind of question to Ian. So Ian, actually, I think one of the attendees also asked, are we able to diagnose spinal stenosis on X-ray? And perhaps if I could extend that question a little bit, pertaining to our ACG recommendation to patients with non-specific low back pain, we do have a little insert that talks about the imaging for suspected vertebral fragility fracture. Can you discuss also a little bit about the role of plain radiographs as a complementary kind of a diagnostic tool to MRI?
Okay, thanks, Heng. So I think I'll echo exactly what Gameliel says, in the sense that the X-ray definitely has a use for X-ray. And I'll add on to that, it's sometimes useful to follow up on X-rays, because X-rays are sort of like simple and easily available to do, not relatively inexpensive. So you can use X-rays to follow up, even if you have a baseline study, a baseline X-ray, and then you treat the patient. With that, you can see the patient, whether it's improving or not improving. And it's quite easy to get an X-ray to follow up to see whether there's any change, as compared to trying to get an MRI, which is, of course, harder to get, takes more resources, and is more costly. Coming to the question about spinal canal stenosis, yes, you can probably see spinal canal stenosis on X-ray, but it has to be at a very advanced stage. In the last MRI case that I showed, with the very large osteophytes, a lot of deformity and spondylolisthesis. So those findings actually can be seen on the X-ray, should be able to be seen on X-ray as well. Maybe not the full extent, but you can actually appreciate a lot of the changes. The main thing that we are missing out and not seeing on the X-ray as compared to the MRI is the lumbar intervertebral disc. So it is in degenerative disc disease that the MRI really it shows the full extent of the amount of narrowing or compression. Yeah, so that's the comment for spinal stenosis. If it's very diffuse spinal stenosis, long-standing, with a lot of osteophytes, of course the osteophytes would be the one that's causing most of the impingement. But if in a younger patient where the X-ray may look more normal, it could be a herniated disc that's actually causing the symptoms, which wouldn't be visible on X-ray. The last,
sorry.
You wanted me to something about osteoporotic fractures. Yeah, so X-rays can show osteoporotic fractures, possibly not at the very early stage, within, say, maybe 2 to 3 weeks, up to a month. But in patients who have had fragility fractures, the end plate will deform and the vertebra will begin to collapse or become misshapen over a period of time, say over the next maybe 1, 2 to 3 months or so, which then can be seen on an X-ray.
Yeah, so, and I guess pertaining to that particular point, there's also a question of, at which point do we proceed then to an MRI spine for those patients with osteoporotic fractures, even without neurological findings? Ian, do you have a perspective on that?
Probably the comment from me as a radiologist, but of course I will defer to the clinicians who actually see and manage the patients, would be that in a patient with osteoporotic fracture, it may be relatively painful for maybe the first 2 weeks or so. And the patient may have difficulty in moving, getting out of bed. But if the fracture heals and does not progress, the pain should gradually tail off over the next maybe 4 to 6 weeks or so. Not completely, and of course, depending on different patients' conditions, it may be slightly faster or slightly slower, but that is probably the expected pathway or progression of a simple osteoporotic fracture without too much deformity. Anything else where the pain actually becomes worse and worse, or the movement is actually even more limited by the pain, then possibly the X-ray is not giving the full picture of the fracture alone, and there may be other conditions that's contributing to the patient's pain.
Thanks, Ian. And so back to Gameliel, I see a few questions on the chat concerning the geriatric population, and I think there's a comment about the fact that despite not having any red flags, it is still fairly, I guess the point that the participant is making is that it's still fairly common to have the various issues related to degenerative disc, facet arthritis, as well as osteoporotic fractures. So Gameliel, perhaps maybe just your perspective in regards to the common conditions in the elderly with low back pain and the value of and the role of MRI in those patients.
Yeah, so for the geriatric population, when we do the scans, there'll be a lot of findings. Most of them are non-surgical, but you can at least explain to the patient where the pain generators are coming from. For example, facet arthropathy, degenerative disc disease, disc bulges, spinal stenosis, deformity. So all these things actually can add up to the constellation of back pain and even radicular pain for the elderly population. And it helps them to explain, to accept why are they having pain, what they can do in terms of physiotherapy, or how can you modify their lifestyle. A lot of them don't really need surgery unless it's debilitating. But it does give a lot of information for the geriatric, and helps them to make sure that there's nothing more serious and to placate them. So Cher, maybe I just want to answer one of the questions before. Can you make a diagnosis of spinal stenosis without MRI? Yes, you can make a clinical diagnosis of spinal stenosis, but then to localize the level, is it 4-5, 5-1, is it lateral recess, foraminal, central stenosis, what's the surgical approach? You still need an MRI for the confirmatory portion of the spinal stenosis, just to close that off.
Thanks, Gameliel. And a question to Kamal, and this is pertaining to patients with the red flag symptoms or clinical scenarios, and here specifically patients with history of malignancy and mild symptoms. What would you consider your threshold for MRI spine? What would be some of those indications that you would use to help you guide your plan? Thanks.
So I think if such a patient turns up to a neurology clinic, I mean, important things, of course, is the past history of cancer. I think that becomes the most important marker of considering that this patient may have something more worrisome. So if a patient has a past history of malignancy, I think my own threshold would be lower to go for the scanning. But of course, the other things are always the systemic red flags, which we did speak or we saw in that particular slide, where you have a weight loss which is unintentional, patient is feeling pain all the time while even lying supine, yeah. So if you can see that these are some of the points which we were talking about. So if the patient has an unremitting pain, then I think in such patients, I would have a lower threshold, and I would probably suggest an earlier MRI. Yeah.
Thank you. And what about, on this point about red flags, there's an interesting question. Is low back pain on coughing or lying supine at night markers of something serious?
So We typically associate increased intra-abdominal pressure or Valsalva maneuver, for that matter, as one of the sort of not signature signs but possible signs of patients having the herniated disc and all that, because the radicular pain does get worse if there is increased pressure and there will be more pinching on the nerve roots as such. So yes, it is. So if it is, I would say if it's only a solitary episode, I think we can ignore, but the patient consistently talks about that sneezing, coughing, or even laughing loudly does result in some pain. I think that does suggest that probably the radiculopathy is more significant.
Thank you. And I guess a question related to the surgical perspective for Gameliel here. I think Ian showed a very nice case post-op and complications. So the question is, how soon then can exercise begin after discectomy? Can we start after the first 2 weeks after microdiscectomy?
Yeah, so for our patients, we tell them no strenuous exercise, at least for 6 weeks. And now for some of these patients, we actually prescribe a lumbar corset so they remember to keep their back straight on neutral. No bending, no heavy load. So at least 6 weeks, as Ian mentioned, for the annulus to at least scar down, and that would decrease the rate of a recurrence. But if they are manual workers, if they are construction workers, obviously I think 3 months might be better. So they go on light duty for a little longer before they go into manual labor again. But for most of us sedentary office workers, it's at least 6 weeks.
Okay, thank you. And if a patient who already has degenerative disc disease and chronic low back pain, now presenting with acute worsening but no other significant neurological signs, does this warrant an MRI, or we can afford to wait and observe? Do you see, I guess this may be quite a common presentation in the orthopedics outpatient as well. So patients with already a history of back chronic spinal degeneration and then with acute worsening pain, how would you approach these patients?
Yeah, so whenever there's a change in symptoms or the pain score, let's say previously it was just 3 to 4, now it jumps to 7 or 8, and activities of daily living or the walking distance is affected. Again, history and physical examination, if there are neurological deficits, pain or numbness or weakness, then the MRI would be warranted.
Okay, thanks. Maybe we shift over to Ian for the radiologist's perspective. There are a few questions quite specific to MRI and also the imaging features. So for Ian, you gave an example of an elderly patient with the vertebral bodies, and I think this was the last example, and the comment from the audience is that the vertebral bodies look polymorphic in their density and weightage. Do you have any comments about the appearances in an elderly spine?
Okay. Well, okay, this is not a sort of like radiology interpretation course, but what happens in the elderly patient is that more and more of the normal red marrow gets replaced by fatty marrow. In addition, because of the patient being elderly, there's a lot of, there's the whole lifetime worth of stress and load being placed on the vertebral end plates as well. So if you look at the image on the left side, you can see that the areas adjacent to the end plate are whiter, which basically means they have more fatty marrow inside it. And the slightly darker areas are the residual red marrow or normal marrow inside. So we do accept a slightly more heterogeneous appearance of this in an elderly patient. Of course, we still have to be aware of the patient's clinical condition that to make sure that there's no pre-existing history of malignancy or tumor, which can also mimic a similar appearance.
Thank you. And I think the next question, there are two of them and quite similar and quite an important consideration as the work group formulated the ACG, and this pertains to whether we will make recommendation for MRI of the lumbar spine in general, or we were going to specify, when MRI with contrast was indicated and when MRI without contrast was indicated. So I guess specifically the questions were, when should you order an MRI with contrast, and if you are ordering an MRI, do you still need to specify the sequences that are going to be coming with the scan? Ian, your comments?
Okay, so usually the decision for contrast, to give contrast for an MRI, okay, maybe I go back one step. What happens when we give contrast for MRI is that we are looking for abnormal tissues. So in areas where there's most commonly either infection or malignancy, because the integrity of the tissues is broken down, those areas actually show neovascularity or increased blood flow. And those areas will actually take up the contrast. It will help to highlight the abnormal areas from the normal areas around the spine. So the contrast serves to brighten or highlight these abnormal areas, making it easier to detect. So the problem with giving contrast is just like any other drug, there are potential side effects and risks for giving intravenous contrast medium. And for MRI, the contrast medium is a dilute gadolinium-based contrast, which is a heavy metal. So the more common situations where we would be concerned about giving contrast is history of previous allergy, history of renal impairment, because the patients do need to be able to excrete out the contrast medium through their urine subsequent to the MRI. So patients with renal impairment or low EGFR, we may not be so keen to give the contrast at the first stage. Of course, this all becomes a discussion as to the risk-benefit ratio. To be able to make the diagnosis of a malignancy in someone who is not known to have a tumor becomes very important. So we may discuss that with the referring physician, whether the MRI is, whether we should give contrast during the MRI or not. But for example, if it's just a follow-up for some other condition that's already known, and we are just looking for any change in the size or rather than to make a diagnosis, then the indication for MRI may be slightly less strong. But this is all sort of like taken as a case-to-case basis, and that's why radiologists always ask for as much history or information as possible from the requesting clinician.
Thank you very much, Ian. We have about 5 more minutes to the end of the session, and I will probably want to highlight some questions that came in prior to today's webinar, which I think are quite important pertaining to the implementation of the ACG. And this pertains to the role of GPs as well as vis-a-vis the specialists for ordering of MRI. And here I would like to ask Kamal. Kamal, so the specific question is that can any primary care doctor order MRI, or must it be a specialist? And then there's a kind of a follow-on question, which is that are GPs now encouraged to order MRI directly if to rule out spinal pathology for non-specific chronic low back pain?
So I think this question would depend upon how we look at the clinical examination, which a GP, or for that matter any physician is experiencing as he sees the patient. So if we do have definite signs and we think that delaying the MRI because we have to refer through a series of processes to get to the MRI may harm the patient, I think there should be no restriction that way. I mean, in fact, that might help actually an early intervention in somebody who's going through a more possibly a more urgent symptoms. Although I think we do have, I mean, being a city state, I think our systems are pretty in a way that we can send the patients to A&E quite rapidly, and even the rapid deterioration can be picked up and taken care of quite early. So I think it's all about signs and symptoms, but in the absence of signs, I think then the threshold or the comfort level becomes very important for a primary care physician, whether the question he's asking would be answered. Because many a times we have seen that the MRI was done in the lumbar spine, although these symptoms could have been coming from the thoracic spine or even for that matter cervical spine. So I think that's something is very important, which is if we are comfortable with our clinical examination and the history we took, I mean, I don't think so 100% restriction has to be there. I mean, I think they should be free to order as well to expedite the process.
Thank you, Kamal. And I noticed that, Gameliel, you've been very active typing your responses to the various questions as well. And I hope that our participants who have posed those questions are able to read your answers. And maybe I would like to, just for everyone else's benefit, talk about the management of, or rather the conservative management of the low back pain. We have a very nice comment mentioning that there are certain physiotherapists who are able to provide manual therapy. And for pain, the preferred management would be modalities for acute pain management, stretches, mobilization, soft tissue release, exercise prescription, and activity modification. Gameliel, would you like to elaborate a little bit more? There was a comment about lumbar corsets for osteoporotic fractures. And I think the specific question was, can it be bought from the outpatient pharmacy? But maybe more generally, your perspective on the use of lumbar corsets.
So for osteoporotic fractures, usually if you look at the evidence, they don't recommend corsets. But in my practice, I find that it's useful for them for the acute pain, at least when they're seated or trying to stand up for physiotherapy. That corset gives them some assurance, and usually it happens at the at the T11, T12, L1, L2 region, with the mobile, immobile part of the spine is. And a simple corset won't actually be used, wouldn't be high enough to brace, because you need to brace them to around T7, T8, and that's where the thoracolumbar sacroorthosis or duet brace is more appropriate. And these are not usually available in the outpatient pharmacy, where outpatient pharmacy only stocks lumbar corset. So you need to go to either to the plaster room in the SOC or orthosis or prosthesis vendor in the hospital, or or if you're referred out, you can get it from the outside. So they're not usually available in the outpatient pharmacy. Having said that, those are very expensive. They vary from $1,000 to $2,000. So you have to make sure that the patient is going to be compliant to using it. So they usually try it out first before they commit to buying it and paying cash for it.
Thank you, Gameliel. And I note that Kamal is busy trying to answer the last question, which is concerning whether we could apply the same approach to management of signs and symptoms in cervical pathologies. And here today, of course, we are talking about the lumbar spine. And I think, Kamal, do you want to have a quick mention of your response? And maybe just to sum up as well, your perspective on the ACG for MRI of low back pain.
So I think the question was whether the cervical spine disease takes more precedence than the lumbar spine disease in trying to approach for investigations and so forth and so on. But to me, I think they both are equally important. I have seen patients with lumbar spine also having a lot of vesicular problems for ever having a neurogenic bladder, and which can be very troublesome, or a very problematic constipation. So to me, I would say that cervical spine and lumbar spine, they both have the similar situations when it comes to the complications. So I would give them the equal importance. So the last question, I think, is a sum total of what we did present. So to me, a low backache, I think, has to be looked into with the idea that what is the background to it? Is it really going off a few years and it's just unchanged, and patient has had various encounters with other doctors without any physical signs? I mean, we do see this also frequently. Versus the patient had this similar profile, but something has changed. So all in all, I think it does come down to what we said in the very first slide, which is primarily it's the clinical examination and the clinical picture, where we should pay a good amount of time to get a good history, because I think at the end of the day, history is the most important part to determine whether we are looking at even the red flags for that matter. Sometimes we have to proactively ask for red flags. So I think if we do our due diligence, I think low backache can be sorted out even without doing an MRI, or if there are signs which require then early intervention, then we do so.
Thank you, Kamal. And I think we've come pretty much to the end of today's session. And I think I would just like to mention here that the ACGs were designed to address the medical imaging investigations that have high value as well as high impact in terms of the number of procedures being done. And you will see in actually what's already been launched, the ACG for when not to perform a chest X-ray, and subsequently additional ACG on imaging of headaches. So here I would like to thank all our panel speakers as well as attendees for very engaging Q&A session. And before signing off, I would like to remind the attendees, please look out for a post-event survey right after the end. Your feedback is vital to us, so please do fill that in. And with that, we have come to the end of today's webinar. And I wish everyone safe and well and an enjoyable National Day weekend ahead. Thank you.